I'm so excited today because I'm going to be interviewing Dr. Malik. She's a breast radiologist in the Washington, D.C. area. Actually, we connected early on when I started Learn, Look, Locate, and I'm so honored that she is now part of my incredible, incredible team of physicians, really helping me to bridge the gap between people like myself that were way too busy to truly understand mental screening with dense breasts, because that was me. And we're going to talk all about this. So, Dr. Malik, can you please tell us a little bit about yourself and why you decided to be part of Learn, Look, Locate?
Hi, I'm Dr. Anjali Malik. I'm a board certified, fellowship trained breast imaging radiologist. As you said, I'm in the DC area. And advocacy is huge to what I do. It's part of my social media presence and platforms, really educating, empowering, and informing my followers so that they can take charge of their health. And living here in DC is actually, advocacy is a huge part of what I do on the Hill and in the community. So whether it's fighting for coverage for the types of exams that we'll be talking about today, maintaining access to annual mammograms, which we know has been part of the struggle for well over a decade now. These are the things that are very central to my non-clinical practice. And so Learn, Look, Locate obviously fit very well into those interests of mine. So very excited to join and to be hopefully empowering all of the Learn, Look, Locate community on these important topics.
Thank you for that, Dr. Malik. Before we dive into all my questions, because just to share, I was diagnosed with invasive ductal carcinoma literally 6 years ago today. I continue to get normal mammograms.
Yay!
No family. Well, no, before I was getting normal mammograms with a walnut-sized tumor.
Oh, right. Yes. Sorry.
And I was only getting 2D mammography. For someone who was small breasted, thought that that was a big deal, meaning I'll never have breast cancer. For someone who had no family history and had no clue that walking around with that letter saying you have dense breasts, that this was a risk factor. So this is an incredibly important interview to me and to reach women all over the world to truly understand what that means and what do we do about it.
Sure.
So I wanted to start off with the screening in general. With 2D mammography in someone like myself, one of the reasons why I started this is the disconnect. Whose responsibility is it to educate us that I should have been getting 3D no matter what? Where does that breakdown lie?
Sure. Well, of course, previously before social media, which has been, coming of age and which is where a lot of people get their information, health and otherwise. It was the doctor, the patient, and then the patient's or the technologist. It could really fall anywhere along those lines. I don't know that it's anyone's responsibility so much as just having that information, making those options available. Now, I will say, in 2024, 3D mammography is very well near the standard in our country, but certainly 6 years ago, 10 years ago, that was not the case, particularly before there was insurance coverage. So those are the kinds of things, again, when it comes to advocacy, that breast radiologists and others in the breast health and advocacy community have worked to put in place so that everyone could have access to 3D mammography, and certainly those who have dense breast tissue. Also note, by the way, today's interview is happening the day after the FDA made their big reporting requirements that hopefully we'll touch on today as well, which will be, patients will be seeing in their reporting and doctors will be seeing in the reports that they receive as well.
Do you believe, Dr. Malik, there is a huge disconnect of understanding the risk factor for dense breasts for women? Whether there was a note or there's this new FDA mandate, to me, it still doesn't matter because women are busy and they are not educated on this risk factor. So I ask you, do you feel it's hard to get a sense of what people know? I know for myself, that I feel there's a huge void, as do many other advocacy groups out there, educating women about dense breasts, and especially the combination of no family history, that the percentage is 85% of us are getting smacked with this, and then having dense breasts, it's like a double whammy.
Sure. So, I mean, I think that thankfully it's been a conversation that's been happening more and more. And so I do find that my patients are more commonly informed about this, but certainly that was not the case even 5 years ago, maybe not even 2 years ago. People like Katie Couric sharing that she had dense breast tissue and a breast cancer diagnosis. Of course, that really brings visibility to something like this. There's been a lot of legislation, both on the state level and the federal level, or at least pushes towards legislation. And then with this this FDA reporting change, I do think that the conversation is becoming more commonplace. Of course, it's, we're not finished until every single person understands what density means, in that it's a proportion and not a thing. It can change over time. I will say that's one thing my patients have struggled with. For example, if they've previously been told they have dense breasts, and then I tell them, oh, you don't have dense breasts, they say, oh, well, I always have. I didn't know it could change. And, so knowing that it's a proportion, it's related to our hormonal status, our age, our weight, and that it can fluctuate.
I did not know that.
It does not necessarily fluctuate, but it can change over time for some. So postmenopausal women can still have dense breast tissue, but there can be those who, once they're in menopause, and maybe if they're not on HRT, or if they have fluctuations to their weight, they might go from dense to not dense. So these are all conversations I think are really important, and I'm glad that they've become more commonplace so that my patients can be better informed about what density is, what impact it has on their health, what they can do about it.
So in my mind, as I figure out how I'm going to work with this whole essence of what we're doing here, I'm calling it a roadmap. So that people have the true understanding. And if we backtrack 6 years ago before my diagnosis, and I got the note that says dense breast, yet I asked for supplemental screening because I'm educated. So most women don't realize, I guess we should touch on that. If you have dense breasts, you should be getting supplemental screening. Now, understanding your density, A, B, C, or D, from many of my interviews, C and D are really concerning, meaning absolutely you need to get supplemental screening. Is that correct?
Yeah, those are the ones that we recommend considering supplemental screening for. Yes. And some patients base it on their, whether or not they get supplemental imaging on their individual risk. So those Tyrer-Cuzick scores or polygenic risk scores showing what their risk is. Some opt not to. And I think for everyone, it's a personal decision on what your risk threshold is, with the understanding that density can be both a risk factor and a limiting factor in the interpretation of mammograms.
Okay. So before I get into the roadmap, do we ever get that score? Because I never did. I've gone back to my notes and everything. A, B, C, D. How do we find out what we are? How do we know this?
So it has been dated to be reported in many states for the past 10 to 15 years. And as of yesterday, September 10th, 2024, it is actually mandated to be reported nationwide. So in the few states where it hadn't been reported, it is now mandated. So every person getting a mammogram will have a density report on there saying what they are. And if they are in the C or D dense categories, there will be discussion on the role that supplemental imaging can play, as well as what the options might be.
Yay, so happy to hear this. So, okay, so here I am. I don't even know what mine was, to be honest, because way back then, nobody informed me, and I still don't know, which puzzles me. But if, let's just say I get a category D, okay, yay. But what if I'm with a practice that nobody's taken the time, to truly tell me what to do here? But I've learned through Learn, Look, Locate, I need supplemental screening. How do I navigate that? Because what I hear from many of my friends who don't have breast cancer, oh, they want to charge me for an ultrasound. What do we do here?
So it's, it's not that we want to. I mean, we perform a service. So, obviously everyone would like to get paid for the work that they do. The problem that they're actually referring to is the fact that there's not mandated universal insurance coverage for additional or supplemental screening. And so those are actually issues that are of great importance to those of us in the breast health, breast cancer, breast imaging community. So there are several items of legislation that have been put forth, whether in the House, Senate, looking for sponsorship, et cetera. One of them is the Find It Early Act, which is looking to gain universal mandated coverage for ultrasound and or MRI for those with dense breast tissue. Some states have it on the individual level. For example, Connecticut, which is the first state that required reporting of density, and that was based on, now I'm forgetting her last name, but her
Nancy
first name
Capello.
Nancy Capello. Yes, I was like, Rapello was going in my head. And Nancy Capello, who unfortunately was diagnosed with advanced breast cancer. Same, had gotten normal for many years, and then was diagnosed with advanced breast cancer and asked, how could this happen? And they said, well, you have dense breast tissue. So she really prompted this entire movement.
Yes.
And so it started in Connecticut. So Connecticut is one of the states that actually has mandated coverage for ultrasound. I don't know, but also am not entirely sure if there are any states that mandate coverage for breast MRI. I don't think that there are. But regardless, the Find It Early Act is working to gain insurance coverage, these types of tests, ultrasound and breast MRI. And then there's the ABCD Act, which is one that a version of it has been passed again in many states, and it's mandating coverage of additional imaging. So many find that, screening mammograms are 100% covered based on the ACA, or more commonly known as Obamacare. So that mandated coverage of a lot of screening and or preventative health examinations, such as screening mammograms. So that's covered. But then if they're called back, that comes out of pocket oftentimes, or it might be like the 80-20, 60-40, whatever it is that insurance has at the individual level. But a lot of times patients are forced to pay from their deductible. So it really becomes expensive and for many people onerous. And so they might not be getting the additional testing that's recommended or required. And it can delay diagnosis, which we know delays to diagnosis can absolutely affect outcomes and specifically can increase mortality. So the ABCD Act and the Find It Early Act are two ways to try to expand the coverage for breast imaging services beyond screening mammograms. So Find It Early is more related to, the current conversation that we're having about breast cancer screening and dense breast tissue. But the ABCD is just as important since, it does impact outcomes of screening, and those with dense breast tissue might be called back and need that coverage for diagnostic screening.
But this could take a long time, Dr. Malik, to get approval for these acts.
At the national level, sure, but there are these movements at the state level, and many states do have dated coverage for one or both the additional diagnostic imaging and the supplemental screening imaging. So, we're working to get it for everyone, but there are, again, some states that have been able to get coverage. So for those who find themselves in places without coverage, yes, it might be those conversations with insurance companies on an individual level. I do think that the reporting of it could be at least helpful when patients are having these conversations with their insurance company. And then also something like the risk scores, which are more commonly being reported now. So my practice uses the Tyrer-Cuzick risk score. There's also something known as the polygenic risk score. So all of these are basically algorithms that are asking a series of questions like, your age, your weight, your age of menstruation, if you've ever been on oral contraceptives, hormonal replacement therapy, things like that. So it's asking all these questions, family history, et cetera, and it comes out with a score. Density is part of the score. And if that score is above 20%, you're considered high risk. If that score is between 12 and 20%, you're considered intermediate risk. So the average risk of breast cancer is that 1 in 8 over the course of our lifetime, or 12% over the course of our lifetime. It is a little bit harder at this moment in time to get that supplemental imaging for those of average risk, but certainly we are seeing more and more commonly that we're at least able to obtain it for those of high risk. So it's a work in progress. If we are at the very least able to get it for those who are, of known higher risk, I think that's obviously very important. And continue to work towards getting universal coverage for all, so that everyone can make the decisions that work best for them.
So from your perspective, when I hear all of this, this really is a difficult roadmap. I mean, my brain's going left and I'm thinking, okay, we're going to go down that road, but let's make a right turn because I can't get to the left yet. This is still very disconnected in my mind as someone who's sitting here with a double mastectomy, right? So yes, you agree. It's very hard to navigate this.
It's definitely a lot. It is not easy, and nor is nor as straightforward as we would like it to be.
Yes.
Of course, we know that is the state of healthcare in our country, and not just related to breast health and imaging. In fact, I think that comparatively, because we have so many groups that are working towards the same common goal, we're very fortunate in that sense that, once Nancy Capello started the, dense breast or breast density reporting, that there have been so many groups that have been advocating on informing the public about breast density and working with legislators. I think that you'll find that, for example, when you go on the Hill, there are a lot of health legislative aides that are actually quite well informed about breast health and imaging issues, which is, it's very hopeful when you hear and see that, because it means that we've been doing what we're supposed to do and that hopefully we'll get the outcomes that we're looking for. And so I'm hopeful. I know that it is a struggle, but I do think that I'm at least seeing in my patient population, and even on the Hill, that we are making strides.
I would say when I hear you say that, you're in the hub of where a lot of this is going on. I'm out there on social media and I feel for the people that are in very rural areas that do not have the access or even the knowledge, because I didn't have the knowledge. No matter where you live, you might not have the knowledge. So really getting to people in the front lines of this disease is one of the reasons why I started Learn to Locate. Because as I reflect on, 6 years ago, my hysteria over I have breast cancer wasn't only about the fact that I have cancer. It was also, how did I not know this? How did I not know what a tumor felt like? How did I not know to get 3D mammography? How did I not know to get screening like molecular breast imaging? I want to shift to that because I was obsessed, as we all know, about educating myself and reading about ways to really find that tumor. So my tumor was in a blind spot, so it was really missed. Being educated about that is so important, the blind spots on mammography. Can you touch on that? I think it's important. I want people to hear this.
Well, when we are positioning for a mammogram, there is a reason that we're pulling and tugging and pressing. We want to be able to get all breast tissue, and we want to be able to compress it evenly so that we can reduce false positive callbacks while also getting a good view at all of our tissue. So some of the areas that can be missed based on positioning, or based on, if the patient is uncomfortable and they kind of pull back, for example, or further up in the underarm, lower down in the breast, on the sides, things like that. I mean, our breast tissue extends from our sternum all the way to the side, but for most of us, we're getting sort of the meat and bones of it that are in the center. And same for, when they're putting your arm up and you have to go in. I mean, some of us have quite a bit of tissue that extends up into the underarm. And any of that is subject to breast cancer. So if that's what you mean by blind spots, then yes, I mean, they do exist, which is why it's important for us to be doing our self-exams inclusive of all of those areas. I mean, mammograms are meant to include all tissue for all people, but again, some patients, particularly perimenopausal and menopausal women, struggle with things like frozen shoulder or rotator cuff injuries. And so positioning for mammograms might be difficult. Some people have chest wall deformity, something called pectus excavatum, which means they have like a really caved in chest. And it, again, makes mammograms really difficult. So there are people for whom, mammograms might not be able to find everything because their imaging and positioning is suboptimal. In that sense, there can be some blind spots. So we know that mammograms are the best form of population-based screening because the goals of screening are something that is affordable, accessible, easily performed, easily interpreted, cheap. And mammogram checks all those. And of course, it has a relatively good sensitivity and specificity. And so mammogram checks all those boxes. We can have them even in the most rural of places because it is basically X-ray technology, right? And, training someone to be a mammography tech, I mean, they aren't a dime a dozen, but they are still more widely available than some of the other ones that we would go on to discuss. So it is something that you can do more readily to a population. Ultrasound, it is a modality that we use in supplemental and diagnostic imaging. So it uses sound waves. Most people are familiar with it when it comes to pregnancy, looking at the babies. So it uses sound waves. There's no radiation. It's safe for all ages. And it's better looking at either further characterizing things that might have been seen on a mammogram. For example, if a mass is seen on a mammogram, an ultrasound can see if it's a cyst or solid, and it can be used for dense breast screening. So mammograms detect 6 to 8 breast cancers per 1,000 screened. Ultrasounds can add between 2 and 3 additional cancers per 1,000 screened. It is also an anatomic test, though. Both mammograms and ultrasounds are taking pictures of the breast. So when we talk about better options, one you already mentioned, actually we've mentioned a couple, we're looking for functional or physiological tests. So those are tests that through the administration of something into the body, we look at areas of increased activity. So there are 3 typical ones that we talk about. One is MRI. So that's injecting contrast through an IV. It's a gadolinium-based contrast, and MRI is magnetic resonance imaging. So it's based on the magnetism of hydrogen protons. And through its ability to be taken up in areas of increased activity, we double the level of breast cancer detection. So it's a fantastic imaging modality. It's not one that we can do on every person who needs breast cancer screening. It's not cheap. It's not easily performed. It takes 20 minutes as opposed to 5 minutes for a mammogram. The positioning isn't accessible to everybody. You have to lay flat on your stomach. That's, many people aren't able to do that. Some people are claustrophobic. Some people have kidney issues and can't do it. So again, it's not something that can be considered a population-based screening test, but it is fantastic for those who are of high risk and those who have dense breast tissue. There was actually a JAMA study that was released last week, or a paper in JAMA that was released last week that talked about the lives saved by MRI in those who have extremely dense breast tissue. So it's a proven modality. 2 other examples. So the molecular breast imaging, like you mentioned, that is injecting something that is radioactive. So something that's been tagged and again, taken up in areas of increased activity, and you get imaging to evaluate for those areas of increased activity. So again, improved detection, but again, not something that we could perform on everyone. A little bit higher levels of radiation. It requires a hot lab, which are very tightly regulated by the government. So that's not something that you're going to want in rural places where they might not have the staffing for those kinds of things. Outpatient setups might not want to offer something like that because again, it is a lot of regulation and protocols to follow. So fantastic for tertiary care centers, but maybe not something that every center could offer. Then you've got something called contrast enhanced mammography. So that is using your standard mammogram and injecting IV iodinated contrast. So the kind of contrast that is used for CT exams. And again, improved detection. But with that, a lot of people are allergic to CT contrast. People who have kidney problems might not be able to get it. And it does become a workflow issue because it's the mammogram techs who would be doing that. But then who's going to place the IV? IV's going to be difficult, et cetera. So there are a lot of great technologies that can improve cancer detection, but they're still not ones that we could offer to everybody, just based on the limitations of staffing, equipment, et cetera. So it's not saying that we don't want to, it's just right now we cannot. Now, one thing that can improve our availability and accessibility is getting universal coverage for these kinds of things. If you get coverage for it, and if companies are able to more reliably, for example, make money on these modalities, it's the way of the world, right? If they're able to get paid for it, then they are more readily able to get staffing for it and more able to make it accessible. It's never going to be the population-based screening that mammograms are, but still, it would be fantastic to be able to more widely offer these services, particularly with, how many are in high risk and dense breast categories.
So I was quite fascinated with molecular breast imaging because I was so angry that my tumor was missed. And I just want to jump back for a second as far as that blind spot. Mine was hidden behind the you-know-what, kind of hate saying the word, okay? So when it was found, the only notes I got were an architectural distortion is being seen. So I would like you to elaborate on what that means, because of course they knew it was something not right. But before we do that, when I got diagnosed at my cancer center, they wanted me to have an MRI because they thought maybe the tumor was attached to my chest wall. Now, to me, that still to this day is kind of spooky, because if the tumor is that far behind and embedded back there and starting back there, which it wasn't, thank goodness, how do we get to that? So I've asked you 3 questions. I apologize.
Sure. Yeah, no, that's fine. So architectural distortion is one of the things that we look for when we are reading a mammogram. And it is what it sounds like. It is a distortion to the normal architecture or the normal, settings. So the breast tissue changes in its configuration. So the idea being something is causing that tissue to kind of be pulled in and change. It can range from benign entities such as scarring. So it is something we see, for example, in post-surgical areas, or internal scarring from physiologic processes. For example, if a cyst ruptures, sometimes we see scarring there.
Oh, interesting.
So the same as we see scarring externally, like if you get a bad scrape and it doesn't heal nicely or whatever, and you see a scar on your skin, the same concept can happen internally, and it can sometimes look like architectural distortion. There can be atypical things that cause it, and those are on a spectrum of simply atypical to precancerous. And then there are malignant entities that cause it. And so it is one of the things that we look for on a mammogram. In terms of involvement of the chest wall. So breast cancer is most often going to start inside the milk ducts. That's the ductal cancer that you hear about. So majority of breast cancers are ductal in nature. If they are stage 0, that means they are still inside the breast duct, and they are DCIS, ductal carcinoma in situ. That means inside the duct. Invasive ductal carcinoma just means it's gone outside the milk duct. It doesn't mean invasive into anything else unless that's proven. But invasive simply means outside the milk duct. So majority of breast cancers are involved in the duct. They can have local spread and invasion, and that can involve the nipple, the skin, and the chest wall. So
Okay.
if it's a cancer that either originated in the back of the breast or sort of grew backwards, it can involve the chest wall. And similarly, if it grows forward, it can involve the nipple, and anywhere along there, it can involve the skin. How do they get to it? That is part of why we do the imaging that we do, to provide as much information as we can for surgeons so that they can decide their surgical plan. I am not a surgeon. You have a lot of fantastic advisors who are in that space, but obviously they use the information that we provide them to decide how it is. Sometimes it means giving therapy first. That's called neoadjuvant chemotherapy. And they do that to try to shrink a very large tumor, or a tumor that has shown that it has some local invasion. And by shrinking it, they're able to make the future surgical plan a little bit more accessible. It still might mean mastectomy. It still might mean, taking the lymph node out, whatever it might still mean those things. But with the addition of that neoadjuvant chemotherapy, and those are done in tumors that are known to respond, it might help with the surgical plan, or it might be done afterward. Breast cancer treatment is not one size fits all. It really is just dependent on the tumor type, the patient, the data, the location. I mean, it's a lot of different factors that the treatment team uses to come up with the surgical plan. So as to how they get to it, I can just tell you I provide as much information as I can through the mammogram, ultrasound, MRI, or whatever kind of functional imaging that the patient got, so that surgeons and the team can make the plan that works best.
But you can't feel for that, can you? I mean, how do you? I mean, I could now because I've got nothing, but how do you feel for that?
I mean, so I think one of the things that I tell patients over and over is that we are much better at finding breast cancer on imaging than anyone is at finding it on an exam. And that's both clinical and self-exams. So at the end of the day, getting your annual screening mammogram and or any high-risk screening is the most important thing that you can be doing, with self-exams and clinical exams being supplemental to them. There are, in fact, my practice has had a pamphlet or like little card that showed what size most tumors are when they're detected by us versus patients, and even different levels of like a patient who gets routine mammograms and does routine self-exams, et cetera, et cetera. And most often I'm able to find something smaller than a pea, and most people are able to feel something walnut sized. Now, things that can improve our ability to detect something on self-exam are knowing our normal, which is something that we talk about a lot. Your job isn't necessarily to know whether something's cancer or not. Your job is to know if it's new. Understanding that the breasts are not symmetric, right? So nothing is symmetric. So again, just learning like what this breast feels like and what this breast feels like. Doing it routinely. My recommendation is monthly mid-cycle. So if your cycle is a 28-day cycle, with day 1 being the first day of bleeding and day 28 being the last day before the next bleed, then doing the exam at around day 14 will help minimize any hormonal. Reproductive age women are still always going to have some hormonal effects on the breast, but it doesn't minimize them to the degree that it can, so that our normal nodular fluctuations and cysts and things like that happen with menstruating patients doesn't affect the physical exam. So those are some of the things that help us in better detecting lesions on self-exam. But at the end of the day, for screening aged women, we are better able to find them. So I think that self-exams are going to be more important for those who are not of screening age, because we know that 30% of breast cancers happen in those younger than 50. 1 in 6 happen in those 40 to 49. So do the math that I can't do in my head right now. And it shows you ones that are outside of your average risk screening age, which is annually starting at 40. And self-exams are definitely going to be impactful at that age, with the knowledge that they're still mostly going to be benign things, normal tissue cysts or benign lesions, most commonly fibroadenomas.
Well, I want to say this to all the ladies who are above 40 and who are getting mammograms or even below 40, because I never once did a self breast check, never in my entire life. So when this happened to me, that is my biggest kind of aha moment. And even if I had, because mine was hidden in a place that even my gynecologist never checked, something I feel like is really needs to get out there, a little pinching of the situation would have easily found it. Because guess what? When I did get diagnosed, I had my friends feel that tumor, because I believe in paying it forward. Because one of the reasons why I started this was, what does a tumor feel like and how are we supposed to know this? So beyond all the screening and everything, the self breast checks, for so many on social media, has been life-saving. So, but really understanding all the places, and even this conversation about the chest wall is so interesting to me, like, because I forgot even as I reflect back. So this is just great. I mean, this is just, to me, every ounce of what you're saying is so very powerful to anyone who's listening. So thank you, Dr. Malik.
Sure.
It's beautiful to hear this, and in a way that's from someone who's been here and doesn't want anyone to go through this, so we understand it and break it down, right? So as we close out, the navigation of this is still very difficult. So how do we change that? So if I reflect back on 6 years, and if I was just diagnosed today, hopefully I would have known all of this and learned all of this, and someone sent me and I got the note saying dense breast. Walk me through what I need to do so that person can truly know the steps. I know money and all of that is an issue, but you call your gynecologist and say, hey, I have dense breast, because we have to advocate for ourselves. Can you get me in? Like, what do we do? And what do we ask for? Do we say? So for me, I was like, I wanted an MBI. Well, it was too late. I was diagnosed at that point. But that I was so drawn to that, because to me it felt so accurate, almost sort of maybe like a PET scan, but even those can't always be accurate. So I ask you if you could walk us through that so that we can close out with that knowledge.
Sure. So I think number one, it's knowing your breast density and knowing that breast density can only be determined by imaging. So it doesn't matter how our breasts feel. Or, you might hear doctors use all sorts of colloquialisms like, oh, you have like fibrous breasts, or you have nodular breasts, or you have cystic breasts, or you have whatever your breasts feel like on exam to you or to them does not determine your density. Okay. It is what a mammogram, ultrasound, or MRI shows that can tell you what your density is. So you're not going to know your density until you've had that kind of imaging, but it's important that once you do get that imaging to know your density. Number two, I think it's very important for everyone to know their risk. And part of that means knowing your family history. The American College of Radiology actually recommends that risk assessments happen before the age of 30 to be able to identify two things. Number one, anyone who needs genetic testing. And number two, anyone who might need to start high-risk screening. Those go hand in hand. Not everyone that is high risk needs genetic screening and vice versa. If a genetic test is positive, obviously, then they might need high risk screening. But that is why we recommend the risk assessment happening before the age of 30, because we want to be finding, identifying those who are at higher risk as early as possible so that we can screen them as early as possible so that any tumors, cancers that might develop, we're able to detect as early as possible. So, right now we don't know how to stop cancer before it starts, but we do know how to detect it. And so that's what we're trying to do, is get people in that might be of higher risk.
When you say high risk, so my father had lung cancer, my grandfather had colon cancer. Was I high risk? I have no family history of breast cancer. What does that exactly mean?
Sure. So not everyone, even with family history of breast cancer is considered high risk. So that's why I think it's important to do one of those tests, like the Tyrer-Cuzick or the polygenic risk score, like I had mentioned earlier, that can spit out that score. So it's asking again, like, how old were you when you started menstruating? It does go over family
Okay,
history.
yeah, you did say that. Okay.
Ashkenazi Jewish, Black, because oftentimes both those populations have higher incidence of BRCA mutations, for example. And so it's taking all of these non-modifiable risk factors into consideration and putting out a risk score. And so it can help identify those who would benefit from earlier screening. And then we get all of those in and then hopefully catch them then. So, but if you're just average risk and you got your first mammogram at 40 and it comes back that you're dense, then what do you do? I think knowing your risk score at that point is important because it can help you decide what might make more sense for you, and it can help you and your physician make some decisions. So if you're of average risk, or if you're of low to average risk, so 12% or below, you might be someone who says, I just want the mammogram, that's it. You might be someone who says, I want the mammogram and an ultrasound, that's it. Or you might be someone who says, I want the mammogram and the full shebang, I want the MRI, but I know the insurance company might not pay for the MRI because I'm only of average risk. So you just need to be able to have those conversations. Same for intermediate risk, and then same for high risk. So for high risk, ideally you are saying I'm high risk, I've done breast tissue, I'd like to get that MRI as part of my high risk screening protocol. And just getting this knowledge and knowing what the options are, knowing how to get coverage if we're not able to get it passed, knowing the conversations to have with your insurance provider. All of these are why I'm having this conversation with you, so that patients know to be having these conversations. So the two most powerful things to be able to obtain supplemental imaging are knowing your density and your risk score.
Okay. And the last question, I forgot about this, is artificial intelligence in mammography. So as you know, I have Dr. Patel as part of my medical advisors, and we do have a page mammography and the advances being made. But how do we advocate for that? So this didn't come about until after my diagnosis. So how do we make sure that if women want that, which I highly suggest, I think that there's a lot of research showing how great artificial intelligence has been with the advances in mammography. So how do we know our center has it? How do we ask for it? How do we get it? Does it cost more money? Do tell.
All good questions and none with a clear answer. So what I would say is, number one, we've been using some form of AI in breast imaging for at least 2 decades. So computer aided detection is something that's existed long before people were talking about AI.
Okay.
And early versions of computer aided detection were pretty bad. And studies show that they didn't help people like myself who are fellowship trained breast imaging radiologists. They didn't help academic breast radiologists, but they could help those community radiologists who weren't specialized in breast imaging. As we go on with time, AI has improved and it does a better job at being a little bit more sensitive and specific. It does a better job of comparing with, the newer versions now compare with prior. So they're actually able to identify when there's something new. They can better detect or better discern calcifications that might be concerning versus calcifications that are from a lot of different benign etiologies. So it's certainly improving, but AI also has other functions within breast imaging. So there's volumetric density measurement. So with the density reporting, with these things like, mandated coverage or request for mandated coverage, density is more widely now calculated by AI. It was a subjective measurement before, but we don't want it to be subjective anymore if we're, really going to be asking people to get supplemental screening and things like that. We want to be clear on who is dense and who's not dense. AI can do things like detect vascular calcifications, which can have an impact on cardiovascular risk. AI, even within our work lists. So I get like a list of screens that I'm reading, or there's a list of screens that have been done. AI, in some fashions, can bump mammograms with concerning findings to the top of the list. So usually we're reading in, chronological order, but they can bump something up and say, hey, this has a concerning finding, maybe it should get read sooner rather than later. There are some AI programs out there that will rank the things that are harder for radiologists to read at the beginning of the work list. So that's how you start your day instead of reading those at the end of the day. So for example, people with implants, because those are a lot of images, and the implant, things with implants can be a little bit more difficult, or people who don't have priors, right? We know that there are higher callbacks from baseline images or those who didn't bring their priors. Just as an example, there are so many things that AI can do. Have I been super impressed yet on whether it's better at my job than I am? No. I still think there is a role for physicians. I think there will be for a very long time. I think it's a long time before I lose my job to a computer.
Oh.
As to whether your facility has it and if there's a cost for it, that is, of course, on an individual level, you would have to ask. So, for example, we used to have a separate charge at my facility. We did it universally. We had a separate charge that was billed to the insurance, but now there are all these bundled charges, right? So some of this is on an insurance level, some of this is on a facility level, and there's no one straight answer to that. But there are some AI technologies that might be out of pocket costs, again, until we can get some of these bills passed that mandate coverage. Anything that's new, insurance is going to be, insurance is going to hesitate to cover anything. That's their function, unfortunately, in this country. But understandably, newer technologies, they need to prove themselves. They need to be vetted before. There's so many technologies out there. There are even ones, decision support tools, for example, that can help decide whether something, even if it's new, even if it's different, if it's concerning enough for biopsy, or, so there are so many tools out there. And again, there's so many things available to radiologists. At some point, it is about workflow. Like, is it really optimizing my workflow, or is it just another box for me to have to check, or is it another click for me to have to do? And if I'm not getting reimbursed for it, for example, if I don't charge or can't charge or am not paid, am I going to add it on? Does it benefit my patients that much that I should? So there's so many questions to ask, and so many reasons why centers may or may not add these. And it's not as straightforward as, AI is good, let's do it.
Okay. So you've been so generous with your time. This is really incredible information.
Yeah.
Really appreciate it. Is there any closing thoughts that you'd like to share with anyone who is watching this?
Yeah, I think there's a wealth of knowledge on the Learn, Look, Locate website on a variety of topics. So definitely check them all out. I am not the only expert on the site, but I do think that just being informed is one of the most important things that you can do, and taking action based on that knowledge. So hopefully the takeaways from today, get your mammograms, know your density, know your risk, know your normal for your self-exam, and advocate for any additional imaging based on your risk, your density, and your risk threshold. So everyone's different. You do you, your body, your choice. You got to do what's right for you.
This is a whole mini college education, because you're just the beginning. And we hope nobody walks through the doors that I did, and many of us as well. But being educated and empowered at the level of understanding, how to navigate and know what to say, what to do, is really important. And with that, I close us out with Learn, Look, Locate. Make sure that you are educated about all the advances being made, and like you said, know your normal. So thank you, Dr. Malik, and I'm very honored to have this page here on Learn, Look, Locate, which I hope reaches women all over the world. And I hope they watch the whole thing, because I find this to be fascinating and incredible. So thank you.
You're very welcome. Happy to do it.